familiar faces. It's kind of nice to see everybody. Lots of bodies. So I'm going to present to you some of the medical therapies as it relates to what we now call castrate-resistant prostate cancer. Hopefully, Mr. P, I will get it right, but I have no doubt if I steer from any of the facts, I will be veered back on track. So I'm going to start with a case, and this represents a little bit of where I was and where I think we're going to in terms of the options that are available if and when needed. So the typical scenario I would see was, a 70-some-year-old gentleman who actually presented with a 3-month history of bone pain. Bone scan is positive. You go on to get a biopsy, a high Gleason's grade, PSA is elevated, and the initial therapy, as most of you know in this room, is what we call total androgen blockade, androgen deprivation therapy, and this controls the cancer for a nice amount of time. Unfortunately, as cancer does, it develops resistance, mutates, or changes, however you want to phrase it, and sometime later, the symptoms are back, the PSA starts to rise, and this represents a change in the therapy, not a new cancer, but a change in the cells. They've developed some type of resistance, and usually what would happen at the time is you'd go through various manipulations of what they call anti-androgen therapy, adding pills, taking pills, changing pills, trying to manipulate what we call the hormone-sensitive environment. In 2003 and 2004, for the first time, we had some chemotherapy available. I think I was actually asked to talk here when Taxotere came available on the market, and that represented standard of care in advanced disease for the last near decade. And when that failed, unfortunately, we had few options that we could present. It was all about how can we care for you and help you through this. But in the last year, there's been an absolute revolution of options, and all we now have to do is lobby the government to get it, and yes, we are doing that. So, to go backwards and remember that case and look at it as a real potential going forward, just to put this in perspective, this is the most common cancer diagnosis in men, and as our population ages and we are getting better and better at addressing other comorbidities such as cardiovascular disease, this is going to become a very major medical concern. In the last year or so, about 25,000 new cases were diagnosed here in Canada. It's tenfold that in the US. So these are new cases, never mind those that are living with the disease. It clearly starts in the gland. Some grow slowly, but others can be aggressive. And there is absolutely no truth to the fact that just because you are older, it is a benign disease. It can be, but it is not necessarily so. And so, as has been suggested, go get yourself checked out. I think it's your newsletter that calls it the walnut. Yes, it really is a walnut-shaped gland. It is at the base of the bladder. This is a tiny little thing. And again, this is what is causing all that problem. There is a classical growth of your prostate gland with age, and again, that can cause symptoms because it squishes on this tube. This is the tube from the bladder called the urethra, which is the exit tube. And very commonly, as one ages, this gland gets larger, and so this is called BPH, or benign prostatic hypertrophy. And it can be a slow and evolving process, but unfortunately embedded in that somewhere in any one of these lobes can be a prostate cancer. And so, as stated, go get it checked out. The risk factors for prostate cancer are, for the most part, being a male and getting older. So if you fall into those two categories, you are at risk. And as you age, you are at increasing risk. Nothing about your genes. It's just a phenomenon that is true. So there's, unfortunately, the only thing you can do about it is go and check it. There's some question about family history, and yes, that does take place. But if your elderly grandfather, for example, had prostate cancer and was diagnosed at 70, that's not a genetic or a familial link. That's just the natural, I am a male and I am getting older. If, however, you have female relatives with early stage breast cancer, and early stage ovarian cancer, it is in those families that the male is at risk and is potentially a carrier of a gene for early prostate cancer. That's where the familial comes in. Otherwise, the majority of the men will be diagnosed just because you have the opportunity of growing older. Most of the time, early stage prostate cancer is asymptomatic. These symptoms represent growth of the tumor within the gland and thereafter spread of the tumor beyond the gland. You don't want to wait for this, obviously. And so again, as early symptoms come of difficulty in voiding, frequency, this kind of thing, and or just good plain screening, that's what should be the approach. So when a cancer is diagnosed, we go on to what we call stage it. This is what we call this T stage, which represents the growth of the cancer within the gland. It is an important component. Embedded in that, obviously, though, is what we call the biology, and I'll get to that in a second. We also evaluate whether the tumor has spread beyond this gland to what we call the node-bearing regions, and that's sort of the first stomping ground or stopping ground for the spread of cancer. So as you can see here within the stage, as it goes from 1 through to 2, 3, and 4, it either gets larger on one side or starts to involve more of the gland. Well, that's important, but what is also important, over and above what we say is just size, is what I call biology. And this is just a cartoon representation of what we call the Gleason's pattern, where when you get a biopsy, the pathologist will take these core samples and then start to grade it, and it's graded 1 to 5. And this is just the real picture of what they're looking for. So there's different patterns, as I'm sure many of you know, and what they look to see is how closely your cancer cells resemble normal prostate cells. So what you can see here are normal appearing or very nicely appearing glands. There's one line of cells here. They kind of almost all look the same. They're not too crowded. They kind of look reasonably well behaved, not exactly all the same. So this is just the early departure from normal prostate cells. So what we would say, yes, cancer, but very low grade, biologically indolent or favorable, not aggressive prostate cells. This is the next pattern, and what you can see is, it's getting a little more crowded. They look a little more different shapes, different sizes. There's more blue, and the joke is blue is bad. That's what we say. This is pattern 5. This is the most aggressive pattern, and what you can see here is literally blue is bad. You don't see those glands anymore. You don't see anything other than a sea of blue. And so what this is important, it's all about is, yes, size matters in terms of how large it is in the gland, but again, biology also matters. So you can have a small tumor within the gland, but a very aggressive type of cancer, which might spread a little bit earlier, not have a very high rise in the PSA. So it's just not about one factor only. It's about all of these factors that are important at diagnosis and as the disease evolves. The other component we look at, as everybody in this room knows, is PSA. And this is a protein or an antigen that is on prostate cells. It's on normal prostate cells and can be released into the circulation. Prostate cancer cells also elaborate these, not all the time, but most of the time. And clearly, if you've got a lot of prostate cancer early on, most of the time, that correlates well with your PSA. And so again, at early diagnosis, all of these factors are put into play. As the disease evolves, it is not only one or the other, it is all of these things yet again that we look at. As, again, the disease changes, or even early on, depending on circumstances, we will look to see if it has spread outside the gland and where it's spread outside the gland. This is a typical bone scan where you can see what looks like a bony skeleton, and all these black dots represent a tumor deposit in that bone. These bone scans, they're very sensitive, they're not very smart. So, for example, if I punched you and broke your bone, it would show up as a black spot as well. It doesn't say there's cancer in there, it just says there's a problem there. We use it in prostate cancer, we use it in other cancers. It tells us there's a problem here. Again, we have to put it in the context of everything. About 80 to 90% of men who have advanced prostate cancer will have the cancer spread into the bones. It's the most common place. It's a place these cells like to grow in. Interestingly, good or bad, depending on how you see it, as we have more and more therapies and as we can control this disease longer and longer, other sites do become at risk, and this is just a CAT scan of the lungs, and you can see a tumor there, and this is of the liver. So again, it is not a common place in early stage cancer. It can be present. Everybody is different, but again, it is something that we are seeing more and more of as we get more and more therapies. So this is just the natural history. As we talked about, early stage prostate cancer is well over to your left. That's your surgery and radiation. This androgen deprivation therapy is in that bucket of hormone sensitive or early stage metastatic disease. And we're going to be talking about the new therapies as we now enter this more advanced stage of the illness. So just 2 words so we can all be on the same page. Management for early local disease hopefully will cure most of you in this room. It tries to remove the entire cancerous tumor before it is spread. But as you can appreciate, size is only one component, as I said. There's no one size which will dictate when it spreads outside the gland. That is actually more dictated by the biology. And so it's not that your surgeon didn't do it right, it is the cancer got away or escaped from the gland before the surgeon got there, so to speak. So surgery and/or radiation will direct it locally at where the initial tumor was. If, unfortunately, tumor cells have escaped from the gland and have seeded somewhere else, so picture a weed in the garden, and again, the tumors or the seeds have escaped from that weed, buried themselves in the garden, and then have grown some years later. What we do is approach it with what we call this total androgen blockade, which removes the source of the male hormone, the testosterone, from the 2 major sources, which is the testis and the adrenal gland. This is usually lowered by the needle, and there's a whole bunch of those out in the market. It depends on which company. They all work the same way, and it lowers 90% of the production. The pills, and there's different ones as many of you know, will lower the remaining 10% from this adrenal gland. And again, without the testosterone present, we kind of starve the cancer cells. But unfortunately, in most situations, there's always one bad guy that finds a way to grow despite the fact that we've taken away what we thought was all of the testosterone or all of the hormone that can fuel this cancer. So again, what we tend to see is that early response, and then unfortunately, sometime later, in some of you, we see the problem. It's not that it's new, it's just redeclared itself. The resistant cells have started to grow. And we have a definition. It used to be called hormone refractory prostate cancer. We've now changed the term based on a little bit of our learning, but it says that despite using therapies one way or the other that lowers your serum testosterone to a really low level, and we've got numbers that go around it here, but that implies essentially pretty darn low levels, that there is evidence of disease progression either by PSA progression, clinical progression. In other words, we can feel a bump, we can feel a node, we can feel a mass, or radiological progression. You don't have to have all 3, all you need is one of 3. Not everybody will have PSA progression, even though the disease is evolving, for the reason we alluded to. If you've got really, really angry cells, they may not look at all like a real prostate cell, and therefore they may not even elaborate PSA. What we now begin to understand, and the reason we've changed the name from hormone refractory to this castrate resistant, is we've now begun to understand that the prostate cancer cell has other mechanisms to make more testosterone or make more ligand or make the fuel that can refuel the prostate cancer cells again. And so the mechanism or the drugs that we're going to talk about are drugs that block these other mechanisms of producing the male hormone testosterone again. When we see a patient that falls into this, what we call castrate-resistant diagnosis, we further divide you into 3 big groups, and that sort of helps us guide what therapies we think we may want to use and what opportunities there are. Now, this is actually based on data prior to these new drugs. We haven't sort of changed this in terms of these numbers yet, but these big buckets still remain. So that first sort of category within this is you're really, really well, you're on your androgen blockade, you're on your needles, and all of a sudden we see the PSA start to rise. You feel well, there's no evidence on the scan of any new tumors, but the PSA is rising despite that really low level of testosterone. The second grouping here is the PSA is up, but again, not only is it up, we're starting to see maybe a new tumor on a bone scan or on a CAT scan. And here, you're starting to feel a little bit more unwell. You're more tired, you're more symptomatic. The illness is enough of a burden that it's taking its toll on you. And while these numbers are not completely accurate, they reflect a little bit of the burden of the illness that we have to try and manage.